Okay, guys, it is now my great pleasure to introduce to you two amazing ladies. We have Monica Boyer and Angela Dempsey, who will be talking to us about emergency sick day management. Who here has experienced an emergency sick day? And I was like, oh my goodness, what do I do here? Well, these two ladies are going to explain to us exactly some of the tips and tricks that they have done with managing emergency sick days. Give it up. Give a round of applause, everybody.
Thank you. Again, my name is Monica Boyer. I'm a metabolic nurse practitioner from Rady Children's Health in Orange County, formerly CHOC. We went through a name change, but same organization. I oversee our glycogen storage disease program under the guidance of Dr. Wala Al-Hartani. And I'd like to thank the AGSD for the opportunity to speak today, so thank you. I'm also have the privilege of sharing the stage with Angela today, and she is a dietitian from the Medical University of Southern Carolina. And she's going to be sharing some case studies at the end of the presentation. So for today's topic, again, we're going to be talking about hepatic GSDs and sick day management and emergency protocols. And we're going to be primarily focusing on the hepatic GSD subtypes with a propensity for fasting hypoglycemia. Information provided today is based on clinical experience and published guidelines, but because every patient is unique, it's really important that you take any specific management recommendations for either your child or yourself back to your home GSD provider for more precise oversight. As I'm talking today, I'm going to be mostly referencing kind of the parent-child recommendations, but if you're an adult here and have GSD, you can flip the script and also use these same recommendations as well. So our speaker disclosures are here, and it's important that everybody understands that clinical recommendations today are evidence-based and are free of any kind of commercial bias. So our objectives are listed here. I'm hoping by the end of the presentation today that participants will be able to understand why GSD patients are vulnerable during illness, come away with an explanation of the importance of the sick day preparation. We'll be talking a lot about that. Recognize early signs and symptoms of metabolic crisis, explain sick day management strategies for home settings, identify indications for escalation to emergency evaluation and hospitalization, and then review emergency department management principles for the hepatic GSD patients. So here's a hard truth that most parents know, and that's every child, including a child with a glycogen storage disorder, will get sick at some point. In fact, we all know that illnesses are very common in children. They are very contagious. They spread easily amongst child care centers, schools, and even in your own homes. It's very normal for children to get up to 12 viral infections a year in their first few years of life. During viral season, it can feel like our kids are always sick. Antibiotics will not help treat viral illnesses. However, vaccinations can prevent some of the more serious viruses, such as measles, mumps, rubella, and chickenpox, but not the more common childhood viral illnesses that we commonly encounter. Sorry, I'm not advancing these slides. I just realized that. The best way to lower your child's risk for a viral illness is to keep their vaccines up to date, teach them basics like good hand hygiene, including regularly cleaning their hands, using alcohol-based hand sanitizers, and keeping them away from sick exposures when possible. For a child without a glycogen storage disorder, common childhood illnesses can easily be treated at home with a little TLC, over-the-counter remedies, while their immune system fights the virus. However, a child A common childhood viral illness in a child with a glycogen storage disease can start a cascade of symptoms that can sometimes turn dangerous quickly. So why is illness more dangerous for a child with a glycogen storage disorder, or for an adult for that matter? Illness puts an extra stress on the body in a child with a glycogen storage disease or an adult in two main ways. First, when you're sick, you usually don't eat as much and you're drinking less. And in a sick child or an adult with a glycogen storage disorder, their body just runs out of glucose faster than a normal person because it can't pull that stored sugar from the liver the way healthy kids can. Second, illness itself increases energy demands. So fighting fever or infection, or if you're losing extra through like vomiting or diarrhea, glucose reserves are used up even quicker. With both less intake, so you have decreased intake and increased energy demands, you have this metabolic imbalance. There's this rapid depletion of available glucose sources, and you can quickly spiral into hypoglycemia and metabolic acidosis very fast. That is why even a mild illness in a child or an adult with glycogen storage disease can result in a metabolic emergency. So armed with the knowledge that your child or even you as adult are going to get sick periodically, the key to preventing a metabolic emergency is preparation. So we're going to talk about how to prepare for a sick day that unfortunately is oftentimes inevitable. So we're going to start going through a list. Number one, and this is pretty basic, but I'm constantly surprised by especially adult patients, and that is, number one, you should have a primary care doctor. And so many of our adult GSD patients that I encounter, they think the GSD center is all-encompassing, but we are really good at what we do, but you should build a team around you, and that includes a primary care doctor and subspecialty doctors for all the different body systems that might be affected. Like today, we had our hepatologist, we have our bone health doctors. You need to be building a team of experts to care for all the different body systems that are affected. And it's really important to have a primary care doctor. So very basic, but make sure you have a primary care doctor for yourself or your child. So in the case of a younger child, this is usually a pediatrician. For an older adult, it might be an internist or a family practice doctor. It's important to have an established relationship with these doctors so that when you're sick, you can be seen early in the course of your disease or in your illness, especially if there's potentially an infectious process that can be treated. So number one, have a primary care doctor. Number two, know how to contact your metabolic team. Again, this seems very basic, but you should have both a number for daytime contact and for after-hours contact, and those should be saved in your phone so that when things are happening, you know quickly how to get a hold of the people you need to get a hold of. Number three, you should keep your child's immunizations up to date. This can spare your child from the flu or other more serious infections, and this is also true for adults. So adults should be getting their annual flu vaccines, plus other potential vaccines as you're aging, like maybe a pneumonia vaccine or a COVID vaccine or what have you. So keep your vaccinations up to date. It can help spare you from a fever or flu-like illness. Number four, this isn't for everybody, but consider a G-tube for sick day support for certain patients. We recently, in my practice, had a family elect to place an elective G-tube in their 22-month-old with GSD type 3, primarily for overnight and then also for sick day support as needed. And then just a couple months later, after this little one had his G-tube placed, he ended up with a gastroenteritis where he completely stopped eating for a short period of time while this illness was kind of running its course. And With the G-tube, the child was able to stay home, and it likely prevented what would have otherwise been at least a 3 to 5 day hospital admission. And then following the acute phase of the illness, an acute gastro event, there's typically like a week or two where it takes time for that child to fully recover. And during this period of time, there's a lot of tension. If you don't have a G-tube, as the child's getting back to their baseline state of eating. And again, this period the family went through this period with much less anxiety because they could bridge that difference with the G-tube. So again, I know it's not for everybody, but you may want to consider, if you have a young, fragile, 1 or 3, a G-tube for nutritional support and for sick day use. Number 5, keep a fully stocked emergency kit for immediate sick day and emergency use. An emergency might look different where you're living as far as like a natural disaster. I'm from California, so we think about earthquakes there. It could be something like a home fire. Again, preparation is key. I went ahead and listed some things that I think you should consider putting in your child, or again, as an adult, an emergency kit. You want to have some sort of fast-acting glucose, either gel, liquid, or tabs. Zofran is always good to have in there. Whatever starch, cornstarch, glycoside, water, flashlight, blood glucose meters, test strips. It's always good to have extra batteries for any of your electronics like that, Lancets. For the ketotic subtypes, you want to have ketone meter and your test strips. Shelf-stable, both carbohydrate snacks and protein snacks in your emergency kit. Regular formula, and then sick day formulas if indicated for your particular subtype, rehydration fluids, and an emergency room letter. And then lastly, we also recommend for all our patients that they wear a medical ID bracelet. And we don't like to think about scenarios like a car accident where a patient might be transported unconscious to a hospital and not be able to speak for themselves, and let the EMS or the medical provider caring for that person know how unique their metabolism is and their reliance on glucose, and the fact that they need special IV fluids in these emergency settings. So it's really important that as an adult or as a child that you're wearing a medical ID bracelet that identifies you as having glycogen storage disease, so you can get those correct fluids in those situations. So information to be included on the ID tag or bracelet would be your name, your date of birth, your risk for severe hypoglycemia, your emergency contact information, and then contraindications, things like no glucagon or lactated ringers. So whatever you can fit on those tags, but it's really important that you use those as well. So goals of sick day management. Again, before we get into this, I want to remind the audience that GSD patients are medically fragile. Therefore, at the first sign of illness, you want to make sure you're in communication with your clinic. Let them know that your child's fragile and that they're under the weather, so that they can provide guidance in real time and review their home management plan. Goals of initial home management include preventing hypoglycemia and acidosis. And it depends on your subtype what we mean by acidosis, but for the type 1s, that's lactic acidosis, and for our ketotic subtypes, it's the ketosis. So our primary goal is, again, preventing hypoglycemia and preventing those other metabolic derangements towards ketosis or lactic acidosis. With these goals in mind, the following interventions should be considered, but again, please discuss specific management recommendations with your home GSD provider. So number 1, we recommend giving Zofran. If you're not familiar with that, it's a prescription anti-nausea medication. So give it early in the setting of nausea or vomiting, and you can repeat it every 8 hours as needed. But in order to do this, you need to have a prescription on file, and not only have it on file, but have a a current prescription available in your home, because you just never know when you might need this, and you don't want to have to be running out and getting things. Again, preparation is key. So making sure that your provider has given you a prescription and you have it available in home for use when you need it. Number 2, as long as there's no history of renal dysfunction, we recommend giving ibuprofen in the setting of fever. Ibuprofen is generally preferred over acetaminophen in patients with hepatic glycogen storage disease because acetaminophen or Tylenol is metabolized by the liver. But acetaminophen can be used if needed for a short duration at standard dosing, and it often works really well, sometimes alternating ibuprofen and Tylenol. So again, it's okay to use it during short durations at standard dosing. We don't want to villainize Tylenol, but in general, we recommend ibuprofen first, and then you can layer in the Tylenol as needed. And then number 3, adjust your child's regimen, their nutrition regimen, or yours as an adult, the timing or the frequency in consultation with your medical team as needed to meet your child's estimated glucose needs. Again, we don't want you to act independently here. We want this to be in consultation with your medical team. But an example might be maybe to use a continuous feeding like Tolerex if you have GSD1 and a G-tube. Angela's going to talk more about this in detail, and she'll give you a case study to illustrate this point. But in general, sick day formulas are augmenting what you normally do for yourself or your child. A sick day formula itself, they're usually given in less volume, and they're not always nutritionally complete. So it's really important that, again, you discuss this with your medical team. And usually the duration is, we recommend using these for 24 hours or less because of the limitations of volume and the lack of nutritional completeness. So again, in consultation with your medical team. Don't go rogue and do these things. You should, again, have notified your team. They should be aware that you're using a sick day recipe, and you have an agreement around the timing and next steps if things aren't working. Number 4, adjust your child's cornstarch dose or timing, again, in consultation with your medical team as needed. So again, we talked about kind of the mismatch that happens with illness as energy demands go up and intake goes down. There may be a need to adjust things, including their starch volume to meet their estimated glucose needs in the setting of diarrhea or increased energy demands. It's not uncommon in the setting of these situations, loose stools, diarrhea, or increased energy demands, to need a temporary increase in the dose or frequency of cornstarch. And then number 5, you want to maintain hydration. You need to rehydrate with appropriate fluids. And in the setting of vomiting or diarrhea, it's important to choose a rehydration fluid that has electrolytes, but continues to meet the other GSD criteria, like being sugar-free. So examples that might meet the criteria of being sugar-free and contain electrolytes, a couple examples are Gatorade Zero. You can use sugar-free Pedialyte, and then sugar-free liquid IV is another alternative as well. And then number 6, you want to increase home monitoring, ideally with a continuous glucose monitor. I love continuous glucose monitors. I'm a big advocate for them in our clinic, but not everybody loves them. And sometimes people will use them kind of intermittently. And this is a time point that if you don't engage with a continuous glucose monitor all the time, but your child's either sick or you're sick, this is a time to put a CGM on because it allows for more frequent data input about glucose trends. And then also you want to increase the amount of just fingerstick blood glucose monitoring you're doing. And then for the ketotic subtypes, you're going to be using your ketone meter more frequently as well. Why? Because we're trying to, again, maintain those metabolic balances. We're trying to make sure we're not shifting into recurrent into recurrent hypoglycemia or having the shift towards acidosis. And the only way to really truly know that is with increased monitoring. So again, our goals is to try and prevent that cascade from happening. but we know that these strategies, unfortunately, don't always work. So with the best preparation, the best plans in mind, you're talking with your team, sometimes we just can't overcome the cascade of kind of events that are happening. And so number 7 is really important, and that is we need to be able to recognize the signs of deterioration or impending metabolic crisis early. The goal is to recognize these signs or these kind of shifts early so that your child does not present to the ED medically compromised and with significant acidosis. We always try to be more preventative, proactive, if you will, rather than reactive with our patients. Our goal is to always have our kids get to the ED before they're really medically compromised. Signs of medical deterioration include reduced urine output, dry mouth, lips, tongue, feeling dizzy or lightheaded, increased lethargy or sleepiness, persistent high fever, respiratory symptoms, which can include like a worsening cough, wheezing or increased work of breathing, osmotic diarrhea, which is basically having a loose or diarrhea stool every time a child is fed, and then recurrent hypoglycemia. So if your child exhibits any of the above signs or symptoms and is unable to tolerate oral or G-tube feeds or cornstarch, the child must go to the hospital for higher level of care and IV glucose support. And the last thing I want to say about that is, as parents, I think, I gave you the list, but you guys know your child better than anybody else. And if you always have that kind of intuition, if you will, that your child isn't doing well, I feel like that's usually right on, and then act on that. Take your child to the ED, let your provider know that the child isn't doing well, and then listen to that still small voice. I think it's usually very accurate, and take your child in early. Another scenario we don't like to think about, but we want to be prepared and have run through these scenarios in our head in case they ever do happen. But what should you do if you find your child unconscious with critically low blood sugar, or an adult for that matter? From a child's perspective, if the child has a G-tube, you want to give fast-acting carbs, and you can either use a liquid or gel if you have a G-tube. And the dose is generally, just think about a half bottle or tube. You want to raise the head of the bed, and you want to call 911 or the emergency medical services. If there's more than one person around, you can be doing these in tandem. You could be yelling, someone go call 911, someone else is attending to the child and giving the fast-acting carbohydrate, trying to get their blood sugars up. If your child doesn't have a G-tube, then you're going to use a glucose gel product, and you're going to just rub the gel inside the child's cheek, right inside their mouth on the side. You want to give, again, about 5 to 10 grams of carb from the gel, which is about half a tube for a child. The glucose gel will then be absorbed through the child's mucous membranes and enter the bloodstream directly. Again, then raise the head of the bed or turn the child to the side, and then call 911. So again, making sure that you have these products at home in your emergency kit in case these scenarios were ever to happen. You want to be prepared. So let's shift gears now and talk about best practices if your child does have to go to the emergency room, kind of what you can do to best prepare for that. Number one is to have an emergency room letter, and I think these are pretty standard practice now, but most clinics will provide these for GSD patients, and it's usually a one-page document with GSD-specific recommendations and contact information for your GSD provider. We find that these are very helpful. They help to fast-track care. They're especially helpful if you're not going to your home GSD center, if you're going to a smaller community hospital, maybe you're traveling. So having this letter so that you're not having to spend time explaining what your child's GSD is or about their rare disease. You can focus on your child, and it gives those recommendations on emergency room care, and most importantly, how to contact your GSD provider as well for more expert consultation. Number 2, familiarize yourself with the list of agents that should be avoided in patients with GSD. And this is, again, we include this on our ED letters, but this list is not meant to be exhaustive, but focuses on agents that are typically considered in an ED setting. Include items like lactated ringers, which is an IV solution that is not recommended for GSD, glucagon, again, not recommended for GSD, and Augmentum, which is an antibiotic which can cause malabsorption of cornstarch. Number 3, familiarize yourself with a list of preferred antibiotics that have been shared by some centers. I include it here. Although this list is based on what we call anecdotal experience, it's not necessarily evidence-based. Number 4, I like to remind both adults and parents that if dextrose containing IV fluids are not needed in the emergency room, for example, maybe your child fell and broke his arm, or maybe he's there getting stitches, but he's able to eat and drink and blood sugars aren't a problem, then do not start IV fluids. So this would only complicate the child's care in the emergency room. We all know that once you start these things, they have to be tapered off. It just complicates care. So if it's not a GSD kind of hypoglycemia occurrence in that setting, then we recommend not starting IV fluids. But if IV fluids are needed, we do recommend at our center that there's 2 IV lines placed whenever we're using higher glucose infusion rates with dextrose-containing fluids. So D10 is known to be hard on the veins, and when running the line's prone to infiltrate. And you probably know that if you have, if an IV were to infiltrate, because there's this continuous output of insulin, then and you have to abruptly turn the IV off, then there's an opportunity for the blood sugar to really drop quickly. So we always ask that there's 2 IV lines, so if there is this infiltrate, then we can quickly switch things over to a second line. So we do recommend to have 2 IV lines placed, and we have that as a protocol in our ED room at CHOC. And then once the IV fluids have been started, and I think most people are familiar with this, again, they must be tapered off with some expertise as far as when, and we usually recommend once diet and cornstarch have been successfully reintroduced, and that's a time where we can start tapering things off for our hepatic GSD patients. Just a reminder about the importance of communication with your care team when you're sick. If you or your child are seriously ill and heading to the hospital, again, communication is key. Have a parent, family member, or friend notify your GSD care center. I recently saw a patient just last week, an adult patient, and he, when I asked for just a general health update, he told me, oh, I've just came out of the hospital. I was there for 40 days. I'm like, what? And he's like, I didn't want to bother you. And I'm like, so we're not mind readers. We don't know if our patients, especially our adult patients, so I work at a pediatric hospital, but we do see adult patients, and our reach is wide. This patient happened to live, I'm in Orange County, he lived in Los Angeles, so he was in a hospital in LA, which is about an hour from our center. I'm not a mind reader. I have no way of knowing that this patient was hospitalized for 40 days. He was there for not a GSD-related event, but he was on IV fluids. And again, we know that there's complications whenever you put a GSD patient on and off IV fluids. So again, communication so that we can be there to advocate for you and make sure that your GSD needs are being met when you're in the hospital. Your care team can help to coordinate your GSD-related care, send over critical medical records, expedite the admission process, and so on. But it's, again, important that you let us know if you're heading to the emergency room, especially so that we can call and fast-track your care. We want to make sure that your care team is appropriately looped in. And in order to do that, if you can communicate the following details, symptoms that you're experiencing, which hospital you're heading to or admitted to, your current triage status or room number, and then the date and time of your arrival. And then if you're going to go to the hospital, what should you bring? Again, these are kind of basic things, but it's always good to have kind of a to-go bag for the hospital, especially if you have younger, more fragile GSD little ones. Again, there's a lot going on when someone's sick, so if you have a kind of to-go bag ready, it kind of helps. It's one less thing to think about. Things that you want to think about as far as at least knowing where they are and having them together, your insurance card, keep it with your ID and easily accessible. Number 2, your medication list. I recommend when our patients come to the hospital that they bring ideally all their medications in the actual medication bottles. If you bring them in little baggies, they can't dispense them, but bring them in their actual prescription bottles, ideally, your vitamin bottles as well. In the actual bottles. And if you can't do that, at least bring a list so that you can go over that with the medical team on your arrival. Any special formulas that you're using, especially if you're traveling or going to a local hospital, they don't often carry the complex medical formulas that the bigger tertiary centers have. So it's important that you travel with your formulas. And then if you're going to the ED room, that you bring some pre-prepared formula, because it may be several hours before you hit the floor, and if your child's able to tolerate a feeding, they might not be able to mix it up right away. So unopened cans of formula and pre-made formula as well for same-day use. And then it's also important to bring unopened containers of your starch, your glycoside, and your home scale as well. I think it's always good to have some autonomy in case, we don't like think about these scenarios, but in case you need to either redose yourself while you're waiting in the ED or even in the room in the hospital, if things are running really late and your child needs something, then you have the ability to self-administer in that setting. And then GSD appropriate snacks and food items. I think the hospital does their best to provide what you need, but having access to preferred foods, especially for little picky eaters, can make that transition back to the regular GSD diet easier. So having preferred and familiar foods for little ones really can be helpful as you're trying to transition them back to their their normal eating behaviors from illness. Seeing those familiar foods can make that transition easier. And then again, that medical summary or ED letter, which again is that one-page document that we talked about. And then just lastly, just items for kind of comfort, phone chargers, computers, tablets, a comfortable change of clothes for your child and for you as the parent that's going to be staying, bottled water and toiletries, things like that. So I'm going to stop here and let Angela kind of go through some really practical case studies to kind of help illustrate the concepts that I've talked about. So, Angela.
Thank you. Okay. So I think that one of the biggest things that Monica has mentioned, and I can't stress enough, is please don't do anything at home without talking with your medical team. You are seen in a specialty clinic for specialty care, and that specialty care is targeted for you, for the specific individual, and every person is an N of one. So what one person is able to do at home might not be the same exact thing as someone else is able to do at home. So we've talked a lot about the hallmarks of medical management and a little bit about diet and some of the things that we can do to potentially avoid a hospitalization, understanding that a hospitalization is not always preventable. That being said, what are some of the things that we can do at home? And we're going to dive a little bit into that. And I think a lot of this is made possible by the amazing advancements with continuous glucose monitors. So this has really made it so that we have a little bit more flexibility and maybe a little bit, even if we can't avoid a hospitalization, a little bit more time before we have to make a move. So these sick day diets are really going to vary by GSD subtype. So with our GSD ones, we're going to need probably a little bit more carbohydrate in terms of quantity and frequency. Also, these individuals may be more likely to have a G-tube, so we may be able to do some continuous feeds if we need to. We can also have a little bit more flexibility. With ketotic types, we also can't forget protein. We know that when we're sick, we're at risk for muscle breakdown. So we can't just completely forget about protein during sick days. Also, not every illness is the same. So every illness will have to be treated at home a little bit differently. For gastroenteritis with increased losses, we know that a low-fat diet is important because fat is something that slows gastric motility. So when you're vomiting, that's something that can really stress the GI system. So we sort of adjust formulas and feeds for that. We also know that with increased losses, you'll need more fluids and probably more carbohydrate, like Monica said. This will not work for every illness. So there's the lowest threshold to seek medical attention. And to be honest, if you think for a second, maybe I should go to the hospital, go to the hospital. And if for a second you think maybe I should call my team, call your team, because I can speak for probably every provider in here. We would really rather you call too much than not hear from you ever. So very low threshold for medical attention. And also keep in mind at home, normal glucose levels do not equal metabolic control in every single situation. So just because your glucose is 70 doesn't mean your lactate isn't 5. Just because your glucose is 70 doesn't mean you don't have ketones. So please know that just looking at one single number from glucose does not say whether or not you're okay to avoid a hospitalization. These are also extremely temporary fixes, quick fixes at home. Please don't use gels at home to get your way through an illness. Gels are not nutrition. Gels are quick carbohydrate. You're going to spike as fast as you fall. So if we can get some sort of good nutrition going, then we can hopefully at least buy a little bit more time at home, shorten a hospitalization if we're able to get to some sort of transitional diet on the way home, or potentially avoid the hospital, depending. So I work well with examples. I like to, correlate something that actually happened and give practical, history to sort of emphasize what might be able to be done. And this is a fictional case study right here, but I feel like this can help to sort of put the pieces together. So this is a 10-year-old male with norovirus at home. So he's vomiting, woke up in the middle of the night, and parents contacted the physician on call after he vomited his cornstarch, which he received 3 hours later. He's drinking unflavored oral rehydration solution at home, unspecified quantity, and I'm going to touch on that again. Glucose levels on CGM are 45 to 85, currently 80, and trending down based on trends on the CGM. His weight is 37 kilos. His cornstarch dose varies from 35 to 45 every 3 to 4 hours, depending on the time. So you can see his total dose during the day is 280 grams of starch with a dose of 10.6 grams per hour. And he does have a G-tube. So a potential sick day plan for this individual would be remove cornstarch and transition to a high carbohydrate, low fat, or fat-free formula. So this could be done at a continuous rate, or it could be done every 2 to 3 hours, depending on patient preference, parent preference, and collaboration with the medical team. So your team can give you fluid guidelines. We know that during a virus where you're vomiting or have increased losses, fluid and rehydration is super important, and if you can't meet those fluid goals, you do have to go to the emergency room. So depending on glucose levels, you can sort of spread that out if you'd rather give them in smaller pushes. This individual could also do a continuous feed option of 75 mLs per hour. We're going to aim to match carbohydrate with a 24-hour dose of starch or more, understanding that this child's dose of starch and glucose demand is probably higher since he is under stress. Electrolytes for repletion. And I say this because oral rehydration solutions like Pedialyte, a lot of times people think, oh, Pedialyte's giving me carbohydrate and calories, I'm probably fine to just do that. Pedialyte has 100 calories per liter. And I can promise when you're sick, you're probably not able to drink a liter at a given time, and it's not super high in carbohydrate. So it is not a replacement for carbohydrate, it's certainly not calories. So a lot of times when I'm making a sick day diet, I'll add an oral rehydration solution for electrolytes and fluids, not so much for calories and definitely not glucose. Finally, go to the emergency room for any signs or symptoms of deterioration. Here's an example for a ketotic type. This young lady has flu A at home. She has GSD 3. She has URI symptoms with body aches and decreased appetite, but no vomiting, has a fever, and some ketones that they've detected. Her glucose levels appear borderline normal to normal, but are dropping faster than normal for her. So she may be able to go every 4 to 6 hours at home between starch doses, but parents are noticing, okay, at the 4-hour mark, she has ketones, or she's dropping right before we would normally give that dose. In addition to her 25 grams of cornstarch at home every 4 to 6 hours, she also gets 5 grams of underine mixed with each cornstarch dose for an extra 21 grams of protein per day, and her total protein intake goal is set to 75 to 90 grams total. So a plan for her could be to shorten the fasting window to every 3 to 3.5 hours while sick and maintain starch a little bit higher than her baseline at 30 grams, knowing that she probably needs more frequently. Continue to give Undri with the starch, knowing that we might be able to mitigate some muscle breakdown with a little protein, even if she's not eating a whole lot of food in general. So if we give Undri with the starch and give it more frequently, we are subsequently giving more protein anyway. So we're able to give her a little bit more than she would otherwise get without it. We set a minimal fluid goal for her. If she's not able to meet it after 24 hours, she might need to go get some fluids and dextrose. Encourage high carbohydrate bland solids like pretzels, saltines, and again, go to the emergency room for any signs or symptoms of deterioration. So I think all of this to say, with getting back to baseline, what is typical for you, typical for your child after an illness, it can take a little bit of time. Even with something like an ear infection, we can see it take a couple weeks to get back to what is normal for you or your child. So work together as a team, try to transition back to that baseline regimen. If feeding orally, try low-fat, bland foods to start. Maybe don't go right to a burger and fries once you're finally feeling better and have an appetite back. If we go too fast, we set ourselves up to set back. So try to make little changes at a time. It might work best by introducing smaller doses of starch at first and then increasing that dose as tolerated. And use what you do know at home. We don't have lactate meters. We don't know what those levels are at any given point of time. That would be a great idea. But use glucose levels and ketones as a guide. Go by how you're feeling, by what you're able to tolerate, and go from there. These are our references. And thank you for having us both today. It's been a pleasure. Please let us know if you have any questions.
Check.
Sometimes we see it in some, there can be platelet dysfunction in some subtypes, but generally not in the 3s, but they're also common just in childhood, so yeah.
That was my constant ER trip. And as an adult, I've only gone once, and now I recognize the feeling or the symptom. I had these excruciating pains where I felt like something was just breaking in half inside, and it's where ketosis was going up the roof. And very funny question, they asked me, after a number of blood work, they asked me if I had run a marathon. And I'm like, no. And my triglycerides were like close to 1,000, so, yeah.
Katie, I have 2 sons with GSD 9A. I'm relatively new to the GSD world. It's been less than a year since diagnosis. And,
Welcome.
Knock on wood, we've been very lucky since we have been able to stay out of the hospital with illness. I'm an ICU nurse by training, and in my head, I do not want to go to the ER. I don't want to pick up norovirus if I'm going in for something else. At what point, if we're urinating well, like obviously cognition as well, and there's no other symptoms, is there a level of ketones where, okay, you have to go in at this level of ketones, or what is your cutoff in the ketone arena?
I don't like to give a specific number. I would talk through those thresholds with your GSD provider, but a certain low level is somewhat physiologic when you're sick, so you might accept a certain level, working towards normal, of course, but there is a threshold where, based on the scenario, your GSD provider and yourself might say, okay, now it's time. But I would talk through those specifics with your provider. Again, I think it's really good to have that back and forth and be comfortable to be able to call and say, hey, my little one's under the weather, this is what we're doing, and we're all on the same page. It's our goal as well to keep your child at home if possible. But again, understanding that sometimes there are situations where the illness is just overcoming the situation, and it's really best to bring the child in. So you have to be willing, if that decision is made, also to bring the child in, because we understand the risks of exposures and all the things that you talked about. But really, again, the goal is to get the child in early, preventatively, so that you really don't have a very compromised child coming to the ED.
Thank you.
Thank you for this. This was great. Our 2-year-old daughter has type 3A. We live in Phoenix, Arizona, and we've traveled to Houston twice to see family, and she's had some bouts of vomiting and sickness, and our care team kind of theorized that it might be the humidity that was doing that. I guess, would everything that you talked about today, that's not necessarily a virus, but is that true? Can that cause that? And would everything you talked about today apply for something like that?
Yeah, environmental stressors can definitely stress a child, and especially if you're seeing that child. Again, Angela made a good point. Every child's unique, but if you're starting to see that pattern that higher temperatures is a stressor for your child, then you can talk through kind of practical ways to address that with your care team, but making sure that you're covering with adequate fluids, maybe adjusting the plan, but kind of preemptively knowing that if you're going back into that environment, how can we better support our child so that we don't have these cascade of symptoms happening again?
Can I answer?
Sure.
For type 3s, I have noticed and experienced that they tend to have higher fluid needs. So with humidity and sort of a change in temperature, if it was hotter, and in Phoenix to Houston might be kind of similar, but a change in the atmosphere could increase fluid demands. And I've noticed that a lot of metabolic patients in general are pretty sensitive to that. So.
This is just sort of a tip. On top of medical ID bracelets, making sure that your health updated on your phone, because emergency responders look at your phone a lot of times before they look at a bracelet for health data.
As a follow-up to that last question on the heat-related stuff, we were just camping this last weekend. It was 100 degrees. My daughter had no fever, started vomiting. And she wouldn't keep her cornstarch down, but she would keep Pedialyte down, and so probably for 16 hours, all she had was her Pedialyte. Like, in that kind of situation, is that okay for a short period of time? Like, should we have reacted differently?
I mean, I think we need some follow-up questions.
Yeah.
What type?
3A.
3A. How old?
3.5.
Okay. Glucose monitor, continuous
Yes.
monitor, and everything was stable.
Yeah.
Were ketones being checked as well?
No, but I
Okay.
suspect that they
Yeah,
were
yeah.
high. I
She
didn't have the ketone monitor with us on
It
the
probably looked okay on the screen,
Yeah.
but if we dug a little deeper, might not have liked what it showed.
Uh-huh.
But it's hard to say, because hindsight's 20/20, right?
trip. Right. Okay.
But-
Hi, my daughter's 2 years old. She's untyped currently. I was wondering what kind of information and emergency protocols we could set in place for secondary care providers, like when the grandparents are watching or a babysitter, something like that. Like, what can I have in place to ensure that she's safe in situations where I'm not there to be monitoring her?
I think it's just important that anybody that's kind of being a surrogate caretaker understands the complexity of your child's unique needs and what they need to look out for as far as what to do in sick situations, what to do to keep her well. I think in order to turn your child over to someone, either a babysitter or a family member to watch, they would have to have at least those basic understandings. So maybe if you had it written down, I'm just thinking kind of in real time, but maybe having their schedule written down and then kind of what to do if they're sick, maybe having something like that written out. I don't know, parents, have you approached these things similarly?
For us, we have a folder that travels everywhere the child goes. And so I don't want to rely on, like, maybe I left it at the grandparents' house, maybe it's in the car. And so in that folder, we have like snack ideas that they're safe. We have their emergency protocols. I feel like Malia does a really good job on our dietitian on like giving us a detailed school letter. And so sometimes, like, if you look at the protocols you have from your doctor, it will tell like the amount that they need or things like that, to where maybe you tell the person, I'm not needing you to follow this schedule, but I need you to see this for like the info that's on it. And so I have all of our child care providers, read our protocols for the ER and any information the dietitian's given us on like what a carb is, what a fat is. Like, we know that stuff, but the people watching our kids don't necessarily know what a carb is at our level. And so we just kind of keep a folder that has like any and everything that we can think of that might happen and that might, the event I know about, the CGMs, things like that. Like, so just go through what your kid needs in a day and what you use to keep your kid stable yourself. And then, I don't want to say dumb it down, I don't know the better term, bring it down to like a brand new person and what they need. And then have everything written down, because like I know that our grandparents, they get so overwhelmed, even though it's been years and years of this, by trying to think of what, the different things that they've learned in the past. And so if everything's written down, they're not having to flip through text messages or, sticky notes or whatever you left. And so then that way you have your binder for that child, and you can just update it on your computer, every year based off of what they need. And so I think it takes a bit of preparation beforehand, but then you have it after that.
My daughter's GSD 1A, and she's been diagnosed for 7 years now, something like that. Couple hospitalizations a year, flu-like symptoms, vomiting, diarrhea, etc. We have yet to be able to properly manage at home, and let me assure you, my wife is Johnny on the spot with Tolerex, pumps, you name it. Is there anything from your professional standpoint that would be able to help us stay home, or is it kind of a case-by-case deal depending on the patient?
It is case by case, and I want you to know that you could do everything right, and the best place for your child to be is in the hospital, because again, this illness is kind of not responding, or her body isn't responding, and she's not staying stable in the home environment, and the best place for her to be is in the hospital. GSD-1s are very fragile, especially young GSD-1s, so having her in the, I think, again, tipping scales always tip towards more prevention, and bringing them to the hospital early. So again, it's not a parental failure, it's not a failure of your team, it's just that these are very fragile patients, and when they're sick, they often need to be hospitalized. So just know that that's very common, especially in the younger patients, to have a hospitalization a couple times a year in those scenarios. So unfortunately, no. It sounds like you have a great team. They're giving good, wise counsel, and oftentimes the illness is such that the best place for the child to be is in the hospital.
For the record, that's what I tell my wife.
Yeah.
All right, we got time for one more.
Hey, yo. I'm Kelly. I'm 49 with 1A, so definitely not a kid. I heard you say that glucose gels probably aren't the good thing to maintain a diet, but if you're an adult, you can see your own symptoms. I've tried gels before to try to see, like, hey, is this something I can turn around in a couple hours, or am I going to have to go? Is that a reasonable thing if you're an adult, you know your own symptoms, and you can sort of test it out, or is there like a, hey, you're dropping too fast, it's not coming back?
My advice would be, well, I think that what I meant by gelling your way through an illness is you can't just take gels. You know, like have to have some fluid, some sort of nutrition. And if you find that you're responding to a gel and you're keeping it, you know, in a place where you know that you're in a good range, you know yourself. If you find that you can't do anything but gels, that's a red flag. Does that answer your question? Yeah.
All right, thank you, everybody. Again, appreciate your time.